Please join us for this talk on the proven and unproven strategies of cancer prevention.
So we'll start by introducing ourselves a little bit, just so you know a little bit about us before we start talking to you about some of the prevention methods and research that's out there. So I am Erin, and I went to Duquesne University for my undergrad in pharmacy school, originally from Hermitage, Pennsylvania, which is a little small town north of here, if you've never been there. I did do my first year residency at UPMC Mercy, and then now we're both at our second year at Allegheny General Hospital, specializing in oncology. So that's the big stuff.
All right, so I'm going to talk a little bit about myself. My name is Didi, but my original name is Diwara. I'm originally from Nigeria, so I grew up there, and I did my undergrad in microbiology. I relocated here about 7-8 years ago, and I went to pharmacy school at University of Maryland in Baltimore. And after pharmacy school, I said I was going to do a residency because I really liked oncology. So I did my PGY1 at Allegheny General Hospital, and I just stayed back for a second year in oncology. And those are just pictures.
Oh, yeah. She has a lot of great pictures. So that's a little bit about us. And just because a lot of people don't usually meet a lot of oncology, pharmacy specialists, there are a lot of pharmacists now that are moving outside of an actual pharmacy. You go to Walmart or to other retail stores and you see pharmacists there, but a lot of people don't know what the clinical specialists in oncology do. So I thought it'd be a good idea just to have a quick slide just to kind of explain what it is that Rick and Didi and I will do in the future. So there are top 6 things listed here that we often do in the course of our job in any given day. So whether it's inpatient in a hospital setting or in an oncology clinic, a lot of places have clinical pharmacists who can write orders for chemotherapy, so making sure that the dose is correct, depending on your weight, your height, your age, if your kidneys are good, your liver, all dependent on whatever drug you're going to get and all those parameters. We also can verify orders for chemotherapy. So the same thing, just maybe the physician will write the actual order and then we'll double check it just to make sure that it's okay. Also verifying other medications in combination with the chemotherapy that you're going to get. So often, I'm sure some of you have heard from pharmacists that there are interactions between other medications that you take and sometimes the chemotherapy that you may need, or even herbal medications can interact with different types of chemotherapy. So we try to make sure that none of those things are going to interact when you're going to get chemo. We also counsel patients on chemotherapy, all the side effects that can happen with whatever regimen you're going to get, just so that you know what things to look for when you go home and what things that we're looking for when we do all those labs frequently to make sure that we're watching for those side effects. There's supportive care management, so pain management, what pain meds would be best for what types of pain, if there's other issues that are going on besides just the cancer and the chemotherapy, we can help with those supportive care things as well, like constipation, diarrhea, all those types of symptoms that people can get. And then there's also pharmacy specialists that primarily round with teams in hospitals. So they may not go to a clinic and do these activities, but they'll actually manage things from an inpatient side. So you may not see them come into your room when you're admitted in the hospital, but they go around with the physicians and round and look at the charts and all the medications that you get to make sure that they're all safe and there's no interactions inpatient as well. So after that little introduction, I'm going to start by talking about some of the controversies and things that may or may not be proven to help prevent cancer. So sometimes you'll see articles in the news, on television about, if you take this herbal supplement, this will prevent cancer or doing these things. And so we wanted to present some of the actual agents, either herbal agents that have actual data or research behind them that have proven if they're effective for prevention or just general health in patients with cancer. So one thing that's really important in prevention that a lot of people leave out is screening. So we do have some screening tools that are important for patients Generally, at this point, patients don't know that they're sick, but if we can screen patients early for certain types of cancers, there are ways that we can prevent these ones. So there are screening methods for cervical and colorectal cancers that are recommended by a lot of those higher bodies. Physicians would recommend that you get things like colonoscopies at certain scheduled times, that we know that if we find a precancerous lesion and we can remove it, that's a proven way to prevent those types of cancers. So there are screenings for cervical, colorectal, and breast cancers that we can do to find these disease states early so that we could treat it at that point before it gets too progressed. So screening is an easy way for people to prevent cancers. It doesn't involve taking any medications or anything, but just making sure that you're going and getting these regular exams when your doctor recommends them to you, so that if there is something going on, you can catch it before it gets too progressed. So there's bodies like the CDC, which is the Centers for Disease Control and Prevention, that actually offer some of these exams for free or low cost to patients nationwide. And if you go to their website or even talk to your physicians about these things, they can tell you where you can get these screening tests done, even if you can't afford the co-pays for them, so that it'll help prevent those things from happening, because they don't want people to not do them and then years later catch something when it's too late to prevent it. Other things that we know are proven are vaccines. So it's very important in general to stay up to date with your vaccines to prevent different kinds of disease states. And there is a couple that can help prevent some types of cancers. So one is the HPV vaccine, or the human papillomavirus vaccine, that helps prevent some types of cervical or vaginal cancers that is usually given when patients are younger, around the 12, 14-year age range, but some people have not had it, so that is one type of vaccine that people could get to prevent those types of cancers. The other one is getting the hepatitis B vaccine, which can limit your risk of liver cancer over time. So those are the two vaccines that are mostly related to cancers that could be important to prevent or limit your risk of getting those types of cancers. Another important topic is lifestyle things. So this isn't necessarily taking certain kinds of supplements, but just your body health in general. As we were talking to the lady out front today, if you're healthier when you get sick, then it could help you do better through treatments and things. Because if you start off kind of weak, then it's going to be a bigger hit on your body than if you're generally taking care of yourself, you're eating healthily, working out, exercising. All those things can improve your health in general. And so it doesn't necessarily mean that you won't get cancer if you're very healthy. There are very healthy athletes who work out a lot, eat perfectly, and they still get cancer, but it will decrease your risk to some extent from some of the preventable things that you could be doing. So for example, making sure you're getting regular medical care. So that involves some of the screenings and vaccines that we talked about. If you're up to date with your vaccines that your doctor recommends, if you get those screening tests done on time, then that could help prevent you from getting certain types of cancers. Avoiding tobacco, even secondhand smoke. There still are restaurants or bars that you could go to where people are allowed to smoke, and sometimes being in those environments for long periods of time, you're exposing yourself to secondhand smoke from other people smoking, even if you're not smoking. Limiting alcohol use. There's been some data published that alcohol actually increases your risk of different kinds of cancers, and so limiting use of alcohol to, maybe a glass of alcohol a day, or something like that, would be beneficial in preventing your risk for different kinds of cancers. Also, avoiding excessive exposure to ultraviolet light, so no tanning, staying out in the sun for long periods of time without sunscreen, because that could be dangerous in terms of getting skin cancer. Diets rich in fruits and vegetables, are healthy weight, being physically active, getting good sleep are all things that are important to keep your body healthy in general. And so, as I said, keeping your body healthy can help sometimes prevent people from getting certain types of cancers. It's not going to prevent all cancers, but even if you were to get cancer and you were healthier, you would have a better chance of doing better than if you started off really weak and unhealthy. And the last thing is avoiding exposure to certain chemicals. So often, if you read some of the bottles on different chemicals, like cleaning chemicals and things like that, and they have warnings about touching them or exposing your body to certain chemicals, those things are important too. So if something says that you should avoid putting it on your skin or different things like that, then it's usually a good idea to follow those recommendations from the manufacturers or the companies that you shouldn't be exposed to. So the two herbal agents or over-the-counter things that you can take, dietary supplements, that I'm going to talk about today are calcium and vitamin D. And so I'll talk about them separately. First, I'll talk a little bit about calcium, and then we'll talk about vitamin D afterwards. So calcium is really important. It's an essential dietary mineral that can be found in things like milk, cheeses, yogurts, even certain kinds of nuts, vegetables, and it's a major component of maintaining healthy bones and teeth. So it's also required for helping your blood clot. So if you cut yourself, the clot that forms to stop you from bleeding, it's important to have calcium, normal functioning of your muscles, your heart, your nerves, all those things. It's very important to have calcium. And so the chart that I have listed here on the left-hand side lists age ranges, and the recommended amount of calcium per day that you should be getting. And so for most adults, the safe upper limit, so the highest amount of calcium that you should be taking in per day is around 2,500 milligrams or 2.5 grams. So in general, for patients who are 19 to 50 years old, about 1,000 milligrams a day or 1 gram per day is the recommended amount to take. For 51 and older, it's 1,200 milligrams. So there are different ways that you can make sure that you're getting a healthy amount of calcium per day. So you don't necessarily need to take supplements if your calcium is low or you have risk for having weak bones. People who have things like osteoporosis may need to take calcium, but you can get calcium out of your regular diet. And here I have listed some of the common foods that people can eat and how much calcium is in those foods. So you can also tell which kinds of foods have high calcium content if you're worried about not getting enough calcium in your diet. So things like yogurts, cheeses, milk, even tofu, a meat alternative that you can take that has calcium in it, spinach and beans are things that they recommend to supplement calcium into your diet. So there are two kinds of calcium supplements, so dietary supplements that you can actually buy over the counter at the store. And one is calcium carbonate and the other is calcium citrate. So they're both different forms of calcium, but they have different amounts of elemental calcium within them. So that's the actual amount of usable calcium that's in that particular tablet. So calcium carbonate is 40% of actual usable calcium versus calcium citrate is only 21% of usable calcium. So when you're deciding what calcium supplement to buy, sometimes people don't know what the difference is between the different products. The difference is the amount of actual usable calcium that's contained within that tablet. So just because it says a certain number of milligrams on it, that doesn't mean that that's the number of elemental calcium within that tablet. Yes? So there's like cereals and other types of products that companies make now where they're fortifying these products with vitamins in them. You can see on the box in the nutrition section how much calcium is actually in it. So even though it may not be a food that's listed as one that has a lot of calcium within it, yes, it is true that some of those products they are now putting calcium into. And so it'd be a good idea to kind of look at the nutrition facts and see how much calcium is in it and if that's enough for your daily intake. But yes, that's a good point. And so when you're looking at the two different kinds of calcium, it's notable that it takes twice as much calcium citrate than calcium carbonate to obtain the equivalent amount of elemental calcium. And generally, when you look at certain products, sometimes cost is a factor as well. There are some calcium carbonate products that are cheaper than calcium citrate, so it's kind of a double bonus using that component versus using the calcium citrate. Yes? No, it's just that the companies that make them, they generally tend to be cheaper. So I've had some cases where patients were worried about cost, and a lot of the generic dietary supplements that you can get at like CVS and Walmart, the ones that are cheaper tend to be the ones that are calcium carbonate. I don't know that it has anything to do with the elemental form. Yeah, so it depends on the company that's making it, how much they want to charge. But in general, when patients are having cost issues, I found that there are some calcium carbonate supplements that tend to be cheaper that you can get that are still made by good companies. Yeah. Yes. So yes, so there's some data about absorption, which is different than the amount that's in them, that calcium citrate would be absorbed more than the calcium carbonate, which may be why there's more elemental calcium in the other one. That, I'm not quite sure why they formulate things the way that they do. But yes, there's when you look at the instructions for taking calcium supplements, sometimes, it'll say whether or not how much it would be absorbed and how you should take it, with certain or without food or things like that. So that's kind of where that comes from. Mm-hmm. Mm-hmm.
Well, if you get too much calcium, does it go in your arteries?
Into your arteries if you get too much calcium. So you can't have high calcium, which sometimes people notice things like muscle type twitching and things like that, because it is part of going into your muscles. Like I talked about, it kind of helps with like blood flow and those types of things. But usually if you're getting regular blood work and they can see that your calcium is high, most of the time we would just ask that if you're taking supplements that you stop taking them. If there was some reason which you had such a high amount, and it's starting to mess with your kidneys or something like that, and you needed to go to a hospital, there are agents that we could give inpatient where we could help bring your calcium down if it were to get too high. So you can, as I said, the recommended max was that 2.5 grams, but if you have kidneys that aren't working as well to clear nutrients throughout your body, you could get too much calcium within your system and need to maybe not take supplements, or would have to have fluids or an agent to help you clear calcium out of your body. Yes. So you could have your calcium level checked. They can take blood and see, what your calcium levels are. So that would be something that I would talk about with your physician, whoever's primarily taking care of your health, and say, is my calcium okay? Asking if you should be taking calcium supplements, if you're getting enough, if you have a healthy level already in your body, would be the best idea. And if you want to do like a blood test or something to see, then you could ask to do that as well. So I wanted to talk a little bit about the evidence of using things like calcium to help prevent types of cancers. And the one area where you see some research studies is with colorectal cancer. And so the American Cancer Society and the Nurses Health Study has looked at if calcium is useful in prevention of cancers like colorectal cancer. And so in the first study with the American Cancer Society, they found that there was a benefit plateau, so a height of 1,200 milligrams per day, where they didn't see any benefit of taking any more than that in a day. So if you take a lot of calcium above that recommended amount, it's not going to have any extra benefit for you to go over the 1,200 milligrams a day. And they did see a 30% reduction in risk for people who took calcium supplements of 500 milligrams per day or more. So between the 500 and 1,200 milligram per day range, in this study, they did actually see some risk reduction in patients, not as much reduction with calcium from diet, but in this case, patients were taking supplements between 500 and that 1,200 range and seeing some decrease in risk. However, in the second study, the Nurses' Health study, they found that there was no association between calcium intake and risk of cancer in a certain part in the proximal, the middle or upper part of the colon. But patients who had a calcium intake of 700 milligrams per day had a 35 to 45% lower risk of cancer in the lower part of the colon. So there's some data about, having calcium supplements prevent certain types of colorectal cancer, but it's not necessarily consistent data. People are seeing different things in different studies. So we do see sort of a relationship between higher intakes of calcium, taking calcium supplements, and reduced risk of colorectal cancer, but those results aren't necessarily consistent, so we don't see the same thing in every patient in every study. And there is a relationship between higher calcium intake and reduced risk of other kinds of cancers like breast and ovarian cancer, but again, the association isn't necessarily proven and a clear-cut answer as to does calcium prevent cancer. So some research would suggest that taking calcium supplements could be beneficial to you to prevent cancer, but they can't say that that's 100%. If you take calcium supplements, you won't get these types of cancers. So the National Cancer Institute does not recommend the use of calcium supplements specifically to reduce cancer risk, specifically colorectal cancer risk, because of the fact that the evidence is limited and not necessarily consistent. So in general, if you're taking a healthy amount, maybe making sure that it's okay with your physician, and if you want to take calcium supplements, getting your levels checked and seeing that if that's appropriate for you, it may help with your general overall health, but it's not necessarily guaranteed that it would prevent cancer. So that's a good question, and to be honest, I don't know the answer to that of, mechanistically, how does that work? People have tried different herbal agents and seeing because of, some of the claims that people make and the data that's out there to see that if it works, but the mechanism by which calcium would prevent cancer, that I do not know. But it's a good question. And those are some of the theories that are out there, different types of oxidation and free radicals, and you hear those with a lot of these supplements. But one of the reasons why they're not recommended is if we can't prove a dose and a specific mechanism by which something is actually working and we don't see it working in patients, then it's hard to prove that that is beneficial to people and to say it does prevent cancer. Some of it, yeah. Yeah. So the other thing is vitamin D and cancer prevention. And so vitamin D is a fat-soluble vitamin that doesn't really have a lot of activity by itself, but the body kind of uses vitamin D to turn it into different hormones that does have activity. So it helps the body use calcium, which is why you often see it given together, vitamin D and calcium, and phosphorus to make your bones and your teeth strong. So they kind of go together. So skin exposed to sun can actually make vitamin D in your body, and you can also get it from different kinds of foods. Some people do have vitamin D deficiency, which can cause weakening of bones, things like osteomalacia in adults. So there's two different forms of vitamin D. One is vitamin D2 or ergocalciferol, and one is vitamin D3 or cholecalciferol. So one is made naturally by plants, and the other can be made in the body when the skin is exposed to light. You can take both of these in supplement form. Both forms are eventually converted into the metabolite, that one listed there, 25-hydroxyvitamin D, that is used in the body. It travels throughout the blood to the kidneys, where it's further made into other active forms of vitamin D that work in your body. So one of the most accurate ways of determining whether or not you have a good level of vitamin D is to measure that metabolite, the 25-hydroxyvitamin D in your blood. So just like with the calcium, they can measure the amount of vitamin D in your blood and know if you have a good level, if you have low vitamin D or if yours is normal.
Can that cause decay in your bones and your teeth?
Like not having good vitamin D?
Yeah.
So it's good for bone health and for your teeth as well. So if you have low levels of things like calcium and vitamin D, then you may have weaker bones and it can affect your teeth as well. Yes.
I have vitamin D deficiency, and it just, I take the supplements for like a 12-week course, and then they recheck it,
Mm-hmm.
and then I kind of plateau for a little bit, and then I drop down. I almost have to be on it for a long period of time. They gave me vitamin D3. You said that both of them, one is from plants and one is made in the body by ultraviolet light, that both of them are equally as good, so it doesn't matter whether you take D2 or D3?
So they come in different amounts. So cholecalciferol you often see over the counter because there's lower amounts in each tablet versus the other one, like the green pills that you see are higher amounts of vitamin D. So often if you get those, it's from a prescription from from a provider. So your PCP or someone may prescribe that to you. So the difference is in the amount of vitamin D that's contained in those products. So they are different, and again, they're in different stages of being converted into the vitamin D that's active in your body as well. So they are actually different in this case from that perspective.
Should you combine, does it help to combine calcium and vitamin D together for the absorption of vitamins?
So they're good to take together because they work together to make your bones and your teeth stronger. So often people will take them together. However, sometimes people have a really low level of vitamin D, so they need that higher count pills of vitamin D to take. Sometimes you take them for a few weeks and then you don't need to take them, and people may have normal levels of calcium. But so sometimes people don't take both of them if they don't necessarily need them. But if your doctor said it's okay for you to just take them in general for your general health, oftentimes they come together in the same product because they work together to make your bones stronger.
If you get vitamin D from the sun, does that show up in your blood?
So that kind of plays into the last point that I made here is that, some people will think that they're increasing their levels of vitamin D by going out and tanning in the sun and those types of things. And you can, sometimes people that live in warmer states with a lot more sun have less incidences of vitamin D deficiency, but that's not exactly a healthy way of getting vitamin D because of the risk of skin cancer. So it's not a recommended way to try to increase your levels of vitamin D by going outside and tanning in the sun, but you can get vitamin D that way because of the way that mechanism works with the ultraviolet light in your skin. So they do have recommended amounts. If you look at recommendations from the Institute of Medicine on how much vitamin D, if you're going to supplement, you could take. So for people 1 to 70 years age, or that includes like pregnant women, it's 600, and it's the amount is in international units per day. Often you see like milligrams or grams on vials for vitamin D, and you'll see IU next to it. And for people who are 71 years or older, the recommendation is 800 per day. And so there is a groups of people that study links between vitamin D and cancer risk. So there's been some earlier research that shows that the incidence and death rates for certain types of cancers were lowered by people who were living in southern latitudes. So kind of, I said, you see less vitamin D deficiency in areas where there's more sun. Sometimes it's more common in places like Pennsylvania to have deficiency because there's clouds all the time here and not as much sun. So they were hypothesizing that, you know, those variations in vitamin D levels may be accounting for that association between differences in cancer risk. And also there's some experimental evidence that suggested associations between vitamin D supplementation and cancer risk. So looking at cancer cells or tumors in rodents like mice, they found in some studies that it might slow or prevent the development of cancers. Not in human models, but these are in animal models. And there's also some additional research that were based with better study designs in humans that were most likely required for people to be able to say that, you know, the changing vitamin D levels, taking vitamin D supplementation would actually be related to a lower risk of cancer or death from cancer. So at this point, there's not a ton of data out there, again, like the calcium, that someone could specifically say if you take vitamin D, you will not get cancer. So there's definitely more trials that need to be constructed, you know, in human models in order for us to actually determine, you know, is there a particular dose? Does it help at all in prevention of cancers or helping people do better who get cancer? There are some studies that are being conducted, and I listed a couple of them here where they're actually looking at this now, so that maybe one day we would have the answer, you know, does it prevent cancer or not? But at this point in time, no one can make that claim that we know, you know, that vitamin D prevents cancer. So it's something that's being studied that maybe in the future, in a few years, we would have the answer to, but at this point, there's no clear-cut answer, similar to the calcium story.
Well, the people that live in tropical areas where they get a lot of sun, do they get less cancer?
That was the one study that some people were looking at where they were kind of seeing that association, but it's not, they didn't actually go through and look at every single person and, you know, do an exact tally on all those. So they were thinking that there's some association between that, you know, maybe it does make a difference, but it hasn't really been proven in any manner in any of those studies yet.
I've moved to Florida yet.
I mean, you can move to Florida for other reasons. So with that, if anybody has any questions about the material I presented, Dee Dee's going to come up and talk about the rest of the information. Thank you.
Okay. So I have an easy and the shorter part of the presentation. We had originally planned to come in October to give this talk, which was the Breast Cancer Awareness Month. However, the class got canceled and we had to postpone to June. So I still have the slides from yeah. Okay, so I'm going to start first by talking about the incidence of breast cancer. And this slide is actually from the NCCN guidelines. We all know that breast cancer is actually the most common cancer in women. And it actually represents about 30% of all cancers that occur in women. So if you look at the chart on the right that represents the woman, we can see that we have it right on top with about 29% in breast, followed by about 14% in lung cancer, and about 9% for colon and rectal cancer. If we look at the other side of the slide for guys, we know that even though men can have breast cancer, it's not very common, and it's actually really rare in men. And the top cancer in men is prostate. So just like I said, it's the most common cancer in women in the United States. Even though it's the most common, it's the second leading cause of cancer-related death in women. I think lung comes before breast cancer. And the good news about breast cancer is that the death rates have actually been on the decrease of recent, and that's because we have a lot of research going on, we have a lot of awareness going on, and there's been a large improvement in treatment options for women that have breast cancer. In 2014, there were about 232 new cases of invasive breast cancer. And out of those 200 people, about 40%, about 40,000 would eventually lead to death. And like I mentioned earlier, breast cancer is very rare in men. And actually, from the American Cancer Society, 1 in 8 women will be diagnosed with breast cancer in their lifetime, which is pretty scary because we have about probably more than 8 women in this room right now. And actually, from the statistics, 1 in 8 women will actually have breast cancer in their lifetime. So what exactly is breast cancer? We all know that the female breast is composed of, I have the pictures on the slide, you have the lobules, you have the ducts and the stroma, and like they all have fatty and connective tissues, they have the blood and also the lymphatic vessels. But cancer is actually a disease that usually begins in normal cells, and eventually these cells, for different reasons, they start to grow out of control. And we all know that normally the cells should die, but cancerous cells, they grow out of control and sometimes they no longer die. And that's when they become a problem and they start to grow and spread to other regions of the body. And breast cancer is likely caused by changes in the genetic material in our cells. So we know there's a lot of genetic factors, and also we have different mutations that go on in the cells that sometimes we can explain that do cause these breast cells to go out of proportion and they start to multiply. So I kind of broke down the risk factors into 2 groups. We have the modifiable risk factors. These are risk factors that we can actually do something about. Unfortunately, we do have some risk factors that, we cannot do anything about. And I'm going to start first by talking about the modifiable risk factors. And the mere fact that you have one of these factors does not mean you're going to get breast cancer. It's just that there's been a lot of studies that have been done, and some of these things have been linked to an increased risk of having breast cancer as compared to the general population. So lifestyle factors are one of the biggest things. So obesity, if you lack of exercise, alcohol use, and also tobacco use, like Erin talked about earlier. And also another big thing is the estrogen exposure. So some people have a lot of estrogen supplements, and that can increase their risk of getting cancer. Other risk factors include the use of postmenopausal hormone use. So a lot of people have, when you reach menopause, you have a lot of, side effects from menopause, and you start to use all these hormone supplements. They've been linked to an increased risk of breast cancer. Other risk factors are the use of oral contraceptives in younger women, people that did not breastfeed when they had kids earlier on in their lifestyle, occupational exposure, like Erin talked about. So we have some people that worked in chemical industries where they got exposed to a lot of chemicals, either from work or even at home. Other risk factors are the environmental pollutants, and also if you had chest radiation. So we have a lot of, younger people that had cancer when they were younger and they had radiation, and later on in life they go on and they have breast cancer. So those are things we can actually, do without. You can avoid to have radiation. If you can decide not to have postmenopausal, hormone use. But for the non-modifiable risk factors, there's really not much you can do about it. So like age, the older you get, the more you have all these changes in your genes, which can lead to an abnormal growth in the cell. So we're all going to grow old one day. There's really not much we can do about that. Also your race, family history. So if you have a first-degree relative that has breast cancer, it actually increases your risk of having breast cancer. So if you have 2 relatives, it increases your risk even further. And if you have greater than 3 relatives that have breast cancer, then you have 4 times higher risk of having breast cancer. Another big thing is the genetic predisposition. So there are a lot of genes, gene abnormalities that happen, but the big ones are the BRCA1 and the BRCA2, and also if you're of the Jewish descent. So a lot of times, like if you have more than 1 family members that have breast cancer, some people like to do genetic testing, and they could let you know if you have any of these gene mutations, just so you get more screening because you had increased risk of getting this breast cancer. Other risk factors include if you have a dense breast density, if you have non-cancer breast problems. So a lot of people at some point in their life might have an abnormal growth in their breast cells, and you go check it out, they tell you it's not cancerous. Even though it's not cancerous, it increases your risk of getting breast cancer later on in life. Also, if you've had it before, we do know that it might definitely come back. If you didn't have any children, or if you had children when you were greater than 30 years, there's some studies that have shown that it does increase your risk of getting breast cancer and also early menstruation. So the big question is, we do know, yeah, you have a question? So it's higher in Black and African Americans compared to white people, yeah. So the big question is, we know breast cancer is really common, 1 in 8 women. Can we really prevent it? And that's a tough question because, no one knows exactly what causes it. If I knew what caused cancer, I'll probably, be very rich. I'll just tell everyone to stay away from something. So there's really no sure way to prevent breast cancer. However, there's some things you can do to reduce your risk of getting breast cancer. Like Erin talked about, regular exercise, eating right. And also you want to make sure you maintain a healthy weight because obesity has been linked to an increased risk of breast cancer. Other things you can do is breastfeeding. Like I talked about, not breastfeeding can increase your risk. I mean, if you already didn't breastfeed your kids, there's really nothing you can do about it now. But, for younger people, we do know that breastfeeding, decreases your risk of getting breast cancer. Other things you can do is to limit exposure to estrogen. So if you can stay away from getting all the estrogen supplements, you should definitely do that. Stay away from alcohol and also limit your exposure to secondhand smoke and also smoke by yourself, like you smoking. So I'm going to talk about chemo prevention briefly. And chemo prevention is just the use of drugs to reduce the risk of the disease. And we do have 2 drugs that have actually been FDA approved to reduce the risk of breast cancer in high-risk patients. And I'm going to be talking about the 2 drugs. So first of all, before you want to think about, preventing, like I mentioned, those 2 drugs were approved for people that have high risk. They recommend for you to do a risk assessment. And the way you want to do that is that we have different tools out there that have been published to assess yourself for your risk of getting breast cancer. The first one and the most common one is the Gill assessment that was done a while back. And basically what the Gill assessment does is that it tells you a 5-year and also a lifetime estimate of your risk of getting breast cancer. And what it takes into considerations are some of the risk factors I already talked about. So your age, your race, the age at menarche, the age of your first live birth, number of relatives that have breast cancer, the number of breast biopsies you've done, and also the presence of ADH. There are some limitations to the Gill assessment, and that's why the National Cancer Institute and also the NSABP came out with a modified Gill, which is the new preferred tool for risk assessment for people that do have breast cancer. And I have a website there, and I also have a screenshot, so anybody can go online, and all you have to do is just answer a couple questions, and it tells you what's your lifetime risk of getting breast cancer. However, you definitely do want to make sure you talk to your doctor, and also you tell him about the results of the tests. And this chart just gives you a brief summary of when you should take the drug or not. So after you do your risk assessment, if your 5-year lifetime risk is greater than 1.67%, then it's recommended to take either of the drugs. Well, there are 2 drugs like I mentioned. And the first question you want to ask the person who has the risk assessment is if they're postmenopausal or not. And that's because only 1 drug is approved for patients that are not postmenopausal. For people that are postmenopausal, you could use either of the 2 drugs, the tamoxifen and the raloxifene. These 2 drugs have some contraindications. So if you've had an history of DVT, PE, stroke, if you're pregnant, or if you have any inherited clotting trait, then your doctor would not recommend for you to use the drug. And that's because we all know that a lot of drugs have, side effects. And that's why they're not approved for everybody. So we want to be sure that your lifetime risk is really high and the risks that come with the drug actually, the benefits, outweigh the risk of the drugs. And that's why we do the assessment. So these are the 2 studies that actually got the drug approved. The first one was it's the tamoxifen for prevention of breast cancer study. And they looked at about 13,000 women who were aged 35 and older. And they just randomized people. So a group of, half of the patients got the drug, tamoxifen 20 milligrams, and half of the patients did not get the drug. And what they looked for was the incidence of, the number of patients that got cancer after a certain number of years. And what they did find out was that the use of the drug actually reduced the risk of getting cancer by about 49%. So that's a huge number. But like I said, the drug does have its side effects. So you have to make sure you pick whoever you use it with. And also the drug works for estrogen receptor positive tumors. And what that means is that we do know that some of the breast cancer cells, they feed off of estrogen. So if you have that kind of breast cancer, that's when the drug works the best for you. The other study was the P2 study, and that also randomized about 19,000 postmenopausal women, because the second drug you can only use in women that are postmenopausal. And they randomized them to take either the first drug, the tamoxifen, or the raloxifene. And they compared the incidence of breast cancer over 5 years. And they did find out that the second drug, the raloxifene, is as effective as tamoxifen in preventing the risk of breast cancer. Another thing they found out was that the raloxifene has a lower risk of the clots, the DVT and the VTE, when you compare it to the other drug. So this slide just gives you a brief summary of the recommendations from two major bodies. The first one is the United States Preventive Services Task Force, the USPSTF, and they recommend that women who are at increased risk of breast cancer to be offered this drug. So you could either take tamoxifen or raloxifene based on if you're postmenopausal or not. But they recommend against the use of these drugs if your risk for getting breast cancer is really low. So you have to make sure your risk is high so the benefits outweigh the risk of the drug. The other body is the American Society of Clinical Oncology, the ASCO, and they do also recommend that pre- and postmenopausal women who have an increased risk of breast cancer can take tamoxifen for 5 years to reduce their risk of the estrogen-positive breast cancer for up to 10 years. However, they recommend that if you're postmenopausal and you're at increased risk, you can take the raloxifene for 5 years. So if you're premenopausal, you can only take the tamoxifen, but if you're postmenopausal, you could take either the tamoxifen or the raloxifene. So even though I talked about the drugs, not everybody has a high risk of getting breast cancer, and not everybody will be able to take the drug. The best protection is early detection. And that's why we always tell people, no matter how hard you try, sometimes you can't just prevent it. And the best thing to do will be to catch it early, because the earlier you catch it, then, you have more treatment options, and also you could get surgery and some other therapy that can actually take the cancer away. So it's very important for you to check yourself, because early detection saves lives. And I'm going to talk briefly about breast cancer screening. So like I mentioned, the earlier you catch it, the more treatable it is. And screening can help find these tumor cells when they're really small and they've not spread to other parts of the body. So if the tumor is confined to the breast alone, you could go through surgery and just take out the breast. But if you don't catch it early and it spreads to other parts of your body, then it becomes more difficult to treat, and also you could get more complications from treating. And that's why we recommend for you to screen regularly. And there are 3 types of screening that can be done. The first is the clinical breast exam. The next is mammograms. And the next one is the breast MRI. So I'm going to go briefly over some of the recommendations. The first recommendation I'll be talking about is from the American Cancer Society, the ACS, and they do recommend that women in their 20s and 30s to have a clinical breast exam as part of a regular health exam every 3 years. So they do talk about, we women, we know our body's the best. So a lot of times, if you see any changes in your body and you feel like, this thing does not feel normal, then it's very important for you to talk to your doctor so they can do all the clinical tests for you and also screen for it. For women that ages 40 and older, they recommend having a clinical breast exam by a health professional every year. And they also recommend to have a screening mammogram every year. And you should continue to do the mammogram every year as long as you're in good health. And like I mentioned earlier, you do know yourself. So if you have any changes in your body, you should talk to your doctor right away to see if there's anything going on. For women that have a very strong family history, these recommendations are for the general public. So if you do have a lot, 2 or more relatives and you're at increased risk, then your doctor might recommend for you to get tested sooner than every year. So they might tell you to do MRIs in addition to the mammograms. And even at younger ages, we have people that have to do the mammograms every year just because they had increased risk of getting breast cancer. The next recommendation is from the USPSTF, and they do not have any recommendations for people that less than 40 years. Their recommendations start from women that are ages 40 to 49. So they tell you to talk to your doctor. They do not recommend the clinical breast exam. They tell you to talk to your doctor which tests are right for you and when you should have them. But for women that are ages 50 to 74, they recommend for you to have a screening mammogram every 2 years. So the ACS recommend every year, but the USPSTF recommend every 2 years. So it's very important for you to talk to your doctor and just, ask him when you should do it. Because sometimes it gets confusing when you have different recommendations from different bodies. And for women that are ages 75 and older, they do recommend that there's insufficient evidence to assess the additional benefits and harm of a screening mammogram. So they do believe that a lot of older patients, if you're greater than 75, even though they detect the cancer, like there's really not much they can do about it. But if you're older than 75 and you're really healthy, then you should probably talk to your doctor and see if you should continue having the screening mammograms every year. And like I mentioned earlier, breast self-exams have little value based on findings, so they do not recommend for you to do breast self-exams. And I'll take any questions, if anybody has any questions. For prevention? Yeah, so there's actually a lot of data for treatment. So if you have it and it's an estrogen positive cancer, then they could start you on Arimidex for the treatment, but not for prevention though. Yeah, after they do the surgery, yeah, you could definitely take it. Yeah, postmenopausal. So tamoxifen can be used for treatment and prevention. So they switch you to it. Yeah, a lot of times, it's better if you're, postmenopausal, but if there's really not much they can do, because that's the only other drug that's available. If you've stopped, if you know you're not going to have any more children, and, they could probably just start you on the Arimidex. I think I've seen that done too. Yeah. But there's no data for prevention. These two are the only two that have been approved to prevent if you have a really high risk of breast cancer. It does, and I think that's the major reason why they ask you, you have to make sure it outweighs the risks. Because a lot of times, if you have breast cancer, people die from it. So if you know your risk is really high, then sometimes, a lot of the side effects from tamoxifen are clots, which we can treat. So you just have to make sure you talk to your doctor and just make that decision. And if, the benefits are going to outweigh the risk of the drugs, it does have side effects. And a lot of drugs have side effects. But if you think about it, chemotherapy even has worse side effects too. So if you can prevent, it's just, if you can prevent, it's probably better than you having it and you have to get treatment and treatment and. I know. Okay. Thank you. Does anybody have any other questions besides what we talked about? Oh, excuse me.
For the MRIs, they say not to use for underwire bra. But if you have a normal bra, they have the metal things on the side and your hooks in the back. Now, does that make a difference?
So it's mostly to prevent because of, it's like a magnet.
Yeah.
And so anything that's a strong magnet can sort of get sucked into the machine. And people have actually died from that happening, having metal attached to them. Someone forgets to tell them to take something off. And that's why they recommend that. If they think that it's not that much metal, they may say that it's okay. Or sometimes if people have bras that don't have any metal in them, those things are okay. But it's the metal that it's just a huge magnet. So if you go in there with something metal on, you'll get sucked into the machine very forcibly, and you can get hurt from that. So that's why.
That's why they always ask you to take everything metal off your body.
They said that jeans would be okay, and I figured the zipper and the snap on jeans, that's thick metal.
It depends on, was it MR of your whole body? Yeah, that's probably why, because the jeans is further down, so it's probably not going into. Maybe you didn't go all the way in.
They have recommendations of lists that the technicians have of things that absolutely cannot come in the room and things that are okay to come in the room.
Because if it's your head, then it's your upper body that gets in the magnet, so probably that's why. I don't think the DEXA scans have the metal in contraindication. Yeah, I don't think so.
It may be. I don't know where they do those. If they do them in the same room or something like that. If there's a magnet like an MRI machine nearby, even when they're not in use, they can still attract you into them. So if you go in that room with metal on you, you can still be sucked into the machine even if it's not in use. It's a different type of, it's not the same as an MRI.
And then also, on the mammograms, they used to say the insurance would cover every other year, but not every year.
I know, and I think it's based on the USPSTF recommendations, but if you do have a reason to get it every year, I'm pretty sure, you could talk to your doctor and they will pay for it. Because we do have some people who we know that their risk is high and they need to get it every year. But I think they do pay every other year, and that's because of the United States, that's the bigger body, and they recommend every other year.
So the insurance companies cover preventative medicine based on the recommendations from that body, the U.S. Preventative Task Force. So their recommendations are what they use as kind of their gold standard. So if they only recommend every other year, that's what they generally cover. But if for some reason your risk is high, or your physician could, if he has to talk to them or he or she has to talk to them, then, you may be able to get it more often than that. But they generally follow those guidelines of the United States Preventative Task Force. So whatever they recommend is what's covered.
And I feel sometimes if you have a sudden change in your breast, even though you got it last year, if you go see your doctor, it's going to order another mammogram. So they will pay for it then. So there's some incidences where they've had to pay every year, and they will pay. Your doctor probably just has to do more paperwork just to get it approved.
Any other questions?